welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Today we have Shannon Semenko, who is a PGY2 in emergency medicine at Boston Medical Center, and she is going to be presenting a journal club on evaluating the study called Efficacy of 10%, 25%, and 50% dextrose in the treatment of hypoglycemia in the emergency department, which is a randomized controlled trial.
Hi, everyone. I'm so happy to be here. Thanks for having me. So just to give a little bit of background, I'm sure you all are very familiar with hypoglycemia, but just kind of looking through the different levels and categories of how we actually look at the severity of hypoglycemia. So level 1 or mild is defined as a blood glucose of less than 70, but is 54 or higher. Level 2 or moderate hypoglycemia is a blood glucose of less than 54, and then level 3 or severe is any person who is unable to function because of mental or physical changes due to the low blood glucose. Looking at different etiologies, hypoglycemia can be attributed to a number of different causes, but medication-related hypoglycemia is very common. Tight glycemic control can lead to higher incidences of hypoglycemia, as well as infection and chronic kidney disease. And then in 2018, there was over 200,000 hypoglycemic ED admissions with a prevalence of 9.6 per 1,000 patients with diabetes. So current recommendations based on the American Diabetes Association is to treat with oral glucose if the patient is conscious and able to swallow. And then if unable to swallow or is unconscious, you would treat with IM glucagon or IV dextrose. So the oral glucose dosing recommendations for adults and children who are 50 kilos or more is anywhere from 15 to 20 grams. And then in children who are less than 50 kilos, you would use 0.3 grams per kilo per dose. And then per a Vermont EMS protocol, considering where I'm located at, I thought this would be fun to share. You can use pure Vermont maple syrup, 1 to 2 tablespoons equals around 15 to 30 grams of sugar. And then for IM glucagon for children and adults who are 20 kilos or more, you would use 1 milligram, and then less than 20 kilos would be 0.5 milligrams. And then for IV dextrose, the recommendation for adults and children 50 kilos or more is 12.5 to 25 grams of 10 to 50% dextrose, and less than 50 kilos is a weight-based of 2.5 to 5 mils per kilo of 10% or 1 to 2 mils per kilo of 25%. So just looking at the different fluid compositions of dextrose-containing fluid and keeping in mind our normal serum osmolarity of 280 to 290, 5% dextrose is considered to be iso or hypoosmotic, whereas your 10 to 50% dextroses are considered to be hyperosmotic. And you can see how much glucose is actually contained per 100 mils. All of these studies have evaluated D10 versus D50. The study that we're going to be talking about today is the first one that I found to have included 25 grams or 25% dextrose. So this first study by Moore and colleagues had similar reported findings where they included 5 grams of D10 versus D50 and looking at how long it took to achieve a GCS of 15 and how much dextrose was actually needed to achieve a blood glucose level of approximately 80 milligrams per deciliter. In hypoglycemic patients, they were different aliquots of 5 grams up to 25 grams, which is similar to our study. And then the median time to a GCS of 15 was around 8 minutes with a non-statistically significant p-value of 0.733. There were higher total doses of dextrose given to the patients in the D50 group, however, which was statistically significant. In a retrospective cohort study by Wendt and colleagues that looked at comparing the safety and efficacy of intravenous D10 versus D50 in pre-hospital hypoglycemic patients, they found that the return to normal glycemia, which was measured by the need to re-administer dextrose on arrival, was not really statistically significant difference. And there was also no incidences of extravasation. And lastly, in this study by Hertubis et al., this evaluated the evidence of effectiveness and harms of D50 compared to D10, and then titrated dextrose for EMS management for hypoglycemia. This was a systematic review and meta-analysis that included 3 randomized controlled trials and then 8 observational studies with various dosing recommendations of D50 versus D10, including aliquots, infusions, and IV pushes, all being included. They had various differences, but none were found to be statistically significant. However, the D10 group of adverse effects, there was no incidences versus D50, where there was 4.2% incidence of adverse effects across 9 studies. So now jumping into the study that we're going to be looking at today, this sought to compare the efficacy and safety of 5-gram boluses of 10%, 25%, and 50% dextrose in the treatment of hypoglycemic patients in the emergency department. This was a single-arm, blinded, randomized controlled trial that had 3 different treatment arms, which we will get into the protocol in just a second here. This was conducted at a 40-bed emergency department at an urban tertiary care center in North India, and it was conducted from September of 2021 to February of 2023. Patients who were 18 years or old or older were included if they had an altered mental status defined as a GCS of less than 15, hypoglycemia defined as a blood glucose of 70 or less, and if they were unable to take oral glucose. Patients were excluded if they had received any PO or IV dextrose prior to arrival to the ED. So patients were randomly assigned to one of 3 different treatment arms to receive 5 grams or 50 mils aliquots of 10% dextrose, 5 grams or 20 mil aliquots of 25% dextrose, and 5 gram or 10 mil aliquots of 50% dextrose. And the aliquots were repeated every 1 minute until a GCS of 15 was achieved, or a total of 25 grams of dextrose was given. The 5-gram boluses were chosen based off of the interventions in the Moore and colleague study, and they had at this institution that this study was conducted at 50 mil, 20 mil, and 10 mil syringes readily available in their emergency department. They also looked at the definition of documented symptomatic hypoglycemia versus asymptomatic, which is basically the difference is if you have a blood sugar of less than 70 and you have the typical symptoms associated with hypoglycemia, you would be considered to be documented symptomatic versus asymptomatic. You would not have those symptoms, but a low blood sugar. So there was 213 patients that were assessed for eligibility. 9 were excluded just to not meeting inclusion criteria. And then 65 patients were included in the D10 and D50 groups. And then in the D25 group, there was 74 patients included. The primary outcome looked at the time to achieve a GCS of 15 or baseline mental status. And then secondary outcomes were pre and post treatment blood sugar levels in milligrams per deciliter, total amount of dextrose administered, if patients had episodes of rebound hypoglycemia, and then any incidence of extravasation. Prior to this study, a power analysis was conducted to calculate a minimum sample size of 384 patients with a 5% level of significance and an 80% power level. T-tests were conducted for group comparisons of time taken to regain that GCS of 15 or baseline mental status, both pre and post blood glucose levels, the total dose of dextrose administered, and the incidence of rebound hypoglycemia and extravasation. Categorical variables were presented as frequency and percentage, and continuous variables were presented as mean and standard deviation and median. Data was also analyzed based on an intention to treat basis. So getting into the baseline characteristics, there was no significant difference among age or sex in the patients that were included in the study, as well as GCS at the time of arrival. There was no significant difference. Blood glucose was also similar with a slightly higher median with the D10% group on arrival. Looking at the total time to achieve a GCS of 15, which was our primary outcome, there was no difference with the median across all treatment arms being 6 minutes. Getting into our secondary outcomes, the median for the blood glucose post-treatment was lower in the D10% group, but similar among the D25 and D50% group. There was a higher amount of total dextrose given to the D50% group, and then the maximum dose was also administered more times in the D50% group as well. There was no incidences of rebound hypoglycemia in the D10 or D25% groups, but there was one incidence in the D50% group. And there was no incidence of extravasation in any of the treatment arms. So they did do this pairwise comparison difference after, just to see if there was any significant difference between any of the treatment arms. They did find that in comparing the D10 to D25% groups, there was less time to achieve the GCS of 15 between the two groups, but looking at the other two, there was no difference. And then the blood sugar post-treatment was also not significantly different among any of the different comparison groups. So looking at the strengths of this study, this is the first one to compare the 10%, 25%, and 50% dextrose in hypoglycemia that I had found. And patients who had received the oral or IV dextrose prior to hospital treatment or arrival were excluded from this study. Looking at some limitations, they didn't achieve power, so it's hard to extrapolate to real-world data. There's potential for bias in patient recruitment, just with providers kind of picking who was included. There was mention of that in the article. There was no mention of what the patient's home anti-hyperglycemic regimens were, so we don't know which patients were on insulin versus, say, a sulfonylurea for type 2. There was also a stopwatch used to monitor the timing of doses and time to achieve a GCS of 15. So that could have potentially led to some bias. And they also didn't mention if IM glucagon was listed as an exclusion treatment versus they did mention that patients who received that PO or IV dextrose were excluded. So the authors concluded that there was no difference in 10%, 25% as compared to 50% dextrose in terms of time to achieve that baseline mental status or a GCS of 15 in the treatment of hypoglycemia, and patients who received 10% or 25% required a lower median total dose. As far as my conclusions, a larger trial would validate the results of this study and I think would be necessary if we wanted to actually evaluate this and apply it to real-world practice. D10% or 25% could be a reasonable alternative to D50 to lessen the risk of hyperglycemia or rebound hypoglycemia, but looking at the logistics of this, D25% is not readily available in the US, and with the fluid shortage, we may actually have to be compounding these bedside, and we just don't really have the bandwidth to be wasting fluid bags. Operationally, implementing this aliquot method may be difficult to do versus the D50% is just very easily administered with that IV push and Bristojet, and this study not reaching power makes it difficult to extrapolate from this study alone. So that is what I have, and I will take any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.